All right. My name is Dennis Skogan. I'm currently employed at Clinton Hospital. I work in the Geri Psych Unit.
The what?
The Geri Psych Unit, the Med Psych Unit at Clinton Hospital, where I've been for, I think, 26 years. So, last year they had, as Mary will know, they had their recognition of employees. So I had to say I've been there for 25 years, and they wanted us to say something we were grateful for. So I told them who I was. I've been there 25 years, and I'm grateful they still let me off the Geri Psych Unit. But having said all of that, today we're at the Clinton Senior Center. It's February 1st of 2018, so I'm oriented times at least 3 right now. And what I want to talk about, or what I was asked to talk about, is behaviors that come along when people have some sort of dementia of some sort, be it Alzheimer's disease, be it dementia related to vascular illness, be it, there's any number of 10 I could name off right now, and when I've talked to various people through the years, some people will say there's probably as many as 100. We just don't know what they are yet. So that's what I'm going to focus on. Again, I want you to ask questions if they come up. It's okay to interrupt me, do what you got to do. That's okay with me. So what I want to talk about at the beginning is a little bit of facts that people don't always pay attention to. People who are over the age of 60, 1 in 10 people over the age of 65 probably have a dementia. There's approximately 5.5 million people in the United States who have dementia. And worldwide, there's probably 47 million people who currently have dementia. By the year 2050, they estimate that it will cost $1 trillion to take care of people with dementia. And I'm going to tell you honestly that one of my pet peeves in the last couple of years, because I'm a baby boomer, is baby boomers are going to screw this up really bad because there's so many of them. There's this little thing I learned in school called cohort theory, and it's got to do with people born at a certain time of, people who were born in the 1930s can think of the things of the 1930s, and that's particular to them. Well, people who were born after the Second World War, it goes like this, kind of, up like stairs. All of a sudden, boomers go up here. There's all kinds of baby boomers. Any of you in the last election hear them talk about old people? Not a word. Not a word. They're talking about build a wall, they're talking about this, they're talking about that, but nobody's talking about the financial impact that people who are baby boomers and reaching 65 are going to have on us. It's like, oh yeah, okay. People don't want to talk about this stuff. They're afraid of it. There has been no walk of life I haven't seen on the 3rd floor of Clinton Hospital. And I mean that sincerely. Politicians, physicians. My favorite is to always talk about the nuns, because I was a nice, parochially educated kid. And, for all of you who say, who might say, geez, my mother never said that, or my father never said that kind of stuff, he never acted that way. Let me tell you about the first nun I met on that unit. She would have made a truck driver cry, because what came out of her mouth was something I never heard in parochial school. She swore like a trooper. And I say that to you because it's the perfect representation of what this illness is. Very disinhibited, everything, they can't hold back. They can't hold back. But it's a very scary kind of illness sometimes. Dementia is currently considered the 6th leading cause of death right now. Between the year 2000 and 2014, the amount of deaths related to dementia rose by 89%. 89%. That deaths related to heart disease went down 14%. Of all the leading causes of death, it's the only one that nobody has a treatment for right now. When you reach 65, as I said, 1 in 10 people have this illness. With each passing 5 years, it goes up by at least 5%, or it doubles. So when you reach the age of 85, it's a 50-50 proposition that you could get some level of dementia. And with each passing year, it goes up a little more. The thing that I've seen at Clinton in the last few years that's really striking to me is how many people I've seen who are over the age of 90. Yeah. At any given time, there's been days we've had 6, 7, 8 people over the age of 90. Feisty. Feisty. The oldest I can remember so far is 102. And she had a pretty good left hook, I can tell you that. And there's others. So, I mean, it's really an incredibly interesting thing that goes on. But let me talk a little bit about behaviors that happen with dementia. Dementia is a progressive neurocognitive disorder. Nobody's quite clear. I'm going to cite a couple of things that I found interesting that you might find interesting in terms of what they thought goes on, which is true, but now there's some new stuff going on where it sort of challenges a little bit of what they thought. But there's many, many kinds of dementia, and I'm not going to spend time reviewing all the different kinds of dementia, although I'll talk about them here and there with how some of these things happen. What I'm going to try to focus on is the behaviors, some of the common behaviors that you see, and just talk about what they are so you'll understand a little bit about that, and then maybe try to dovetail those into, it's really hard to stage dementia, if you will, but people will like to talk about, early, middle, late, and I'll sort of put it in that category just so you'll understand a little bit about where this is at. What I can tell you is 30 to 90% of the people who get Alzheimer's disease, for example, have some type of behavioral disturbance. Something goes on, be it they get agitated, be it that they hallucinate, they may wander, their sleep-wake cycle gets turned around, they start waking up at 2 o'clock in the morning thinking they're going to work, they get restless, they pace, back and forth, back and forth, back and forth. Incontinence becomes a big deal sometime. They can't sleep through the night. The disinhibition I just talked about. Most people in the world know who a nun is, and nobody would ever expect that nun to swear at you. But they can, and they do. And I say that again because it's a pretty good representation of what this disease does to people. And it's not just Alzheimer's disease. That's just one variant of these things. Behaviors like wandering, incontinence, hoarding, poor sleep. Oftentimes, when you start to see those happening, that's when the red flag needs to go up, because they're approaching a time when you probably are going to struggle with taking care of them. It's just that's when the real issues start to occur. I can remember a man who was referred to the unit who, any of you who know where Breezy Bend is in the Spencer area, it's a big long turn that goes around. Well, he walked out of it, he opened the window to his house in the middle of a snowstorm, jumped out, and the only reason they found him is they followed his footprints in the snow, but it was right at Breezy Bend. Now you think about that at 2, 3 in the morning on a snowy night with somebody who's cognitively impaired, and what kind of risk that created for him. His wife was so tired from taking care of him that she was sleeping soundly for a change and didn't hear him. Got up and was horrified. these kinds of behaviors are going to show up in some fashion. Not everybody experiences the agitation. The agitation is the one that generally brings people to Clinton Hospital, or one of the main reasons why people come, is because people can't control them, they can't help them, they struggle with what's going on, but all these other things happen. So let's talk a little bit about when you're first diagnosed, or somebody is first diagnosed with some degree of dementia. Probably the biggest thing that affects those people is depression. Because they have an idea. Something's not happening. Something's going wrong. They can't, geez, I'm not remembering this anymore. I'm not doing that. So a lot of times that's what you target, and that's what you try to help them with, because that's really what's going on. They estimate that 50 to 80% of the people who get Alzheimer's disease in that early stage get depressed or anxious. And so you might be able to treat them with a medicine that might help that a little bit. But the thing to always remember about the treatment side of the world is we really don't have any medicine that will make this go away. It still doesn't exist.
Do they believe that depression is a precursor?
No, not necessarily, because you can get people who are in their 80s and 90s who are truly depressed, but have no dementia.
Okay.
I don't think it's a precursor. I think people who may be depressed in their life could be predisposed to some degree, but to me it's more of a effect of what's starting to happen for this person. Geez, I can't remember what I did with this. I'm getting lost when I go to the store. They get kind of apathetic. They kind of don't go out anymore. They don't come to the senior center anymore, which is what was part of their routine on a daily basis, or a couple times a week they came. All of a sudden they're not here. When you talk to them, they're a little more distant. They're sort of, they can't, they don't want to talk, because they don't want people to know that that's what's going on. But then it's sort of the opposite of what you should do. That's when you might want to get here, and maybe somebody can help you, or do something for you, or make a suggestion. Why don't you try this, or maybe we could try that, or maybe we could do this. But it doesn't always happen. And that's not to say that some of these other things I'm not talking about don't start to happen then too. They do, but at the beginning it's the trying to wrap your hands around what's going on, and trying to believe that's what's going on. That's the other scary part, is like, oh my God.
If it's going to cost us that much money in the near future, why aren't we looking into a treatment or a cure?
They are. Alzheimer's disease has been around since probably the early 1900s. That's when Alois Alzheimer found it. The reason why we didn't see as much of it is because people didn't live into their 70s, 80s, and 90s, and now they do. And I agree with you. I think people are very much looking at a cure. And I'm going to talk about one thing that I read about recently that's very intriguing to me. But you're absolutely right, and that's my point of this, in part, is that this isn't going away. If anything, it's going to be more evident and affecting us financially and emotionally and medically in all different ways, because there's going to be so many more people who have this illness. And there are things that they suggest people can do, and I'll chat about that a little bit. Again, the depression stuff. The other thing that happens with Alzheimer's disease in particular is and with other types of dementias, is sort of a change of their personality. They're not as upbeat maybe as they were before. They're not as interested. They're a little more socially inappropriate sometimes. That infamous disinhibition that shows up. That, just when you think nobody would say that, they do. You know, in the middle of church, or, you know, in the middle of the plaza. My father had a hearing problem. He wasn't impaired, but even that, you know, I'd be standing in line with him somewhere at the bank to helping him do something, and he'd say, you know, you gotta go to the bathroom all the time, or it's just, I mean, just, you know, it was okay, but, you know, on any given day, he wouldn't necessarily do that, you know, you know? So, but that's what starts to happen. As the illnesses proceed a little bit and you're sort of moving out of this depression phase, that's when some of the other stuff starts to happen. Hallucinations. Now, hallucinations are a funny thing and very hard to explain, but hallucinations are seeing things that aren't really there. And the thing that's interesting about dementias is that most of the time the hallucinations are visual. You see things. You know, when we deal with, you know, I deal with people with mental illness as well. Sometimes people are talking to you, but with Alzheimer's, it's a little more visual. One of the things you really have to look at if that's occurring, or should look at if that's occurring, is it a medical problem? Do they have macular degeneration? You know, I can remember patients who have come to Clinton Hospital, and they live on a main street. And cars are going by all night. And lights are going by all night. Those lights sometimes become hallucinations. You know, and people who have macular degeneration can't see, you know, things that come right at them. It's the peripheral. My aunt had it, and I remember what she would say to me. You know, it's like you're talking to her like this because she's looking to the side, but sometimes, you know, if you're living with somebody with this, if you help somebody with any of these, and you start to see changes, you know, the first thing you really should do is try to have them talk to their doctor. You know, is there something medically wrong? I mean, even when people come to the hospital, and let's say they're coming up to the Jerry Psych unit, the first thing that's done is we look at them medically. We have to make sure that there isn't a medical, we're trying to rule out, is there an acute medical problem that's happening before they're coming up to the floor. You know, even if they have problems and they're pretty stable or we're working with them, you know, they can come up. But you're always looking for, is there something that has led to this event? You know, the hallucination, if you will, or the agitation, or one of those things. Because you want to rule that out. You know, not only eyes, but ears. You know, when people have hearing loss, it can shut your world down. You know, you don't want to go out. My father had hearing loss, as I said. You don't want to go out. Because if I go, I can't hear anyways. So what happens? The world starts to shrink again. And it's probably the worst thing that you can do if you have some sort of cognitive disorder. You don't want to make the world smaller. You actually want to make it a little bit bigger if you can, so that you get a little more stimulated, so that somebody might say something that, oh yeah, I remember that. You know, the best description of dementia I ever heard was, it's growing up in reverse.
I can't hear.
Growing up in reverse. If you think about it.
Yeah.
You know, you go from being a vibrant, you know, working person to slowly declining to the point where maybe you don't walk as well anymore, you need assist. You start to need help to go to the bathroom. Then you're incontinent, you can't go to the bathroom. Then you can't eat right, and you need to be fed. I mean, you're going full circle. You started with that, now you're ending with that. And you really got to think about that, because that little quote came to me from a woman named Joanne Cody Cost, who has actually written a book about Alzheimer's, who actually started the first, what they call dementia unit in a nursing home, when the state told her they couldn't do that. And she said, I remember talking to her about this, she told me that when you're in nursing homes, Department of Public Health will, on an annual basis, go into a nursing home and make sure they're doing what they're supposed to. So she said the first time she did that, when she was told they couldn't do that, they all came in, and she was talking to a surveyor who said, geez, you know, it's fascinating. All these people seem to have the same diagnosis. She said, isn't that interesting? But she was smart enough to know that if you could start gathering these people together and try to do things with them and try to, you know, have your staff know how to do certain things, that you could help them in a different way, because there isn't a cure. It doesn't exist. Not yet. Not yet. So besides sensory issues, medical issues, you should also always look at, you know, have they changed their medicine? Is there something different going on? It's very interesting what medicines will do sometimes. They can be very helpful, but the standard is that if you're on 7 or 8 medicines, you probably already have a drug interaction. So you need to look at that. As we age, you know, maybe we don't need the vitamin E anymore. We don't need some of these medicines that are helping a little bit. Maybe you don't need that. You know, maybe you can modulate that a little differently, and it makes you a little clearer. Sleep. Sleep is a biggie. You don't sleep good. None of us sleep good anymore, I suppose, when we get to be this age. But sleep is a big deal. You got to try to regulate yourself with some level of sleep somehow, some way. You know, not only do you have this sleep-wake disturbance that occurs, you know, where you literally flip. You know, they literally flip. They're sleeping during the daytime and they're up wide awake at night, making the caregiver crazy because they're walking around. My friend Mary worked the late shift. She understands it all too well.
People will say, oh, you work 11 to 7, they must sleep all night. No.
It's the exact opposite. They don't. And you know, and think about it, if our doors weren't locked, we'd be running up and down Greeley Street all night because that's where they'd be going. It's the reality of it. And the best way to turn your sleep-wake cycle is the sun. That's really the best way to do it. The sun is that regulator of circadian rhythms. So if you can ever, you know, if somebody's struggling with that, not that you can do this all the time, but, you know, get them outside for a little while. Get them out for a nice brisk walk in a sunny day. Will help. Will help. Instead of just medicine. And medicine is okay, and I'm very much an advocate of medicine because there aren't a lot of interventions that you can use. But some medicines aren't really good for older adults, like sleeping pills. You know, they're what they call hypnotics. So you got a person who's confused already, and when you give them something that's going to probably make them more confused, it's probably not a good deal. But, you know, everybody has their own way of dealing with this.
Excuse me, but at the same time, when they put them on that medication, it's to calm them down because they're irritated, because they can really get out of control when they're agitated.
Oh yeah. I agree.
So you have to wait.
And that's what it is, and that's the challenge. That's the challenge. You also have to think about what kind of medicine you're putting them on. When I say sleeping pills, you can sometimes accomplish the same thing by using another type of medicine. Sometimes an antidepressant will work. There's a couple of old antidepressants that actually are pretty sedating, and you might try that because you don't have the same side effect. There's, you know, some days they use melatonin these days, you know, to help, because melatonin is part of our natural body chemistry that helps us go to sleep. Some people it works for, some people it doesn't work for. So you try some different things. The infamous old glass of milk. Give them a turkey sandwich. I mean, there's several different things that exist out there that you can try sometime. But I agree with you, and we'll talk about that a little bit more because when I talk about agitation. So we have sleep-wake problems. We have just the depression of the illness. We have disinhibition. Now, some of these things we're sort of moving from an early stage into a middle stage. The middle stage of any dementing illness is probably the longest stage they're in, and it's probably where most of these things happen, more than not, on some level. Just because I'm going to talk about these doesn't mean that everybody gets these. Some people never get agitated, really. They sort of seem pleasantly confused and just sort of go through it that way. I don't tend to see those people at Clinton Hospital. We don't usually see those. Those are the people who may be doing fine in the community or wherever. I don't tend to see them. On occasion, but for the most part, no. For the most part, we're dealing with people who deal with some of these nasty things that happen in the middle of all this. Because think about this, many of these people, if you knew them, I've heard this a lot. Again, I'm referring to Mary because she was there with me. We've all heard this a lot. None of these want this.
What?
None of these want these kinds of behaviors. They didn't ask for this stuff, and they probably weren't like this in the community, and they probably never did this. But when you get this, all bets are off. All bets are off. So, what else happens? You know, you're not sleeping. They get very restless. Pacing. Pacing to me is like people who say the same thing over and over and over and over again. Perseveration. Perseveration and pacing go together with me. It's a repetitious behavior. Sometimes short of medicating them, but medicating them how far? Because they pace, and that's how they get rid of their agitation. If we medicate them too much, then they fall down. So now we've created a whole nother problem. So you got to think about that, what you're doing with it. Some people will pace to the point where you can't get them to sit down and sit down and eat. So that's where you got what they call finger foods. You give them a sandwich and off they go. Another good story of the unit was the day I was coming off the unit from the back way, and I'm looking down at the doorknob, go, what the hell's that? It was a sandwich stuffed in the doorknob. You never know what you're going to see, You just don't know. It's there, You just don't know. So you have that. Pacing, perseveration. There's two, when I read things, and I looked up some things before I came here, some people will say that's more a feature of sort of the middle stage of the illness. Some will say it's more the end stage of the illness. It's probably both. There is a thing called terminal agitation, which is something you see as people are sort of moving to the other side of life. But this is more of it's just this need to just keep going and going and going. I mean, I describe it as the Energizer Bunny. Just feet are always going. You literally stop them, sit them down sometimes, their feet will still go. They can't stop it. Wandering. Wandering is one of the biggest reasons why people go to nursing homes. For the reasons I told you, the Breezy Bend story. I mean, it's people get up and go. And if you don't have the door locked or the door shut or something, they're gone. And you don't know where they are. And it's horrific for a caregiver. Because how do you sleep with one eye open and one eye shut? Yeah. And how do you rest when that's happening? You don't. And so there's going to be two messages you're going to hear. Yes, I think there's things we can do to treat people, but I'm also going to tell you that you need to take care of you. If you're taking care of somebody who has dementia, you need to take care of you. I've said this once, I will say it 1,000,000 times. I don't need 2 patients. I only need 1. But if you keep doing what you're doing and it's not working and it's just getting worse and worse and worse, and no matter what you try, As hard as this is, I'm not going to say this isn't a hard thing to do. You need to think about you and whoever it is. Because you will break. And if you break, whatever you're trying to prevent is going to happen anyways. So maybe you can do it at a time when you still have your wherewithal and you're still doing okay and you still have some quality to your life. You're not giving up on them. You're not giving up on them. You're being smart because you're recognizing you can't provide the best care anymore. And you need to think about it that way, as hard as this is. I tell you that honestly. My mother had dementia as well. My mother spent 8 years in a nursing home. The last 3 years, she never said a word. Wow. She had an event that occurred one day, and when my father was alive, being the good Catholic man he was, he couldn't make her a DNR. I understood that. I had no right to say anything different. The day the event happened, and I got called from the nursing home at the hospital, remember sitting there, remember the whole event, the first thing I thought about was I got to call the primary care doctor, because she's still full code. Now, did I really want that to happen? No, but what was it that was going to make it all better? There was nothing that was going to make it all better. So we had this discussion, and I get to the hospital, and I look at the monitor, and I'm talking to the doctor. He says, "What do you want to do?" I said, "Really, the only thing I'd like you to do is just make sure she has some level of comfort." Well, she made it through. I saw her that night. I asked what happened. They told me she had thrown 3 pulmonary emboli through a hole in her heart that nobody knew she had. I said, okay. So I go up to the floor where she is, and she's lying in bed just looking, and her meal's there. And I said, yeah, right, she's going to get up and eat, right? So I saddled on up and fed her. But she never, ever, ever said another word to me. The only expression I got out of her one day was when I was talking about the Red Sox, and she burst out laughing. I said, well, I know you're there then. Because she grew up in a time when they weren't doing what they're doing now. So, was it sad? Absolutely. Absolutely. I used to actually consult to the nursing home she was in, and when she first was going there, I said to them, I don't have to do this anymore. They said no. So I always knew what was going on with her, and she was well taken care of, and but there wasn't, at least one time during that year I'd come out of that nursing home crying. Because part of me was just saying, this isn't right. Just let her be. Let her go. It was sad. It was sad. And so I feel for all that. I can understand that part of it. But at that moment, I also had to realize that my father, who was older than she was, who was calling me at 3 in the morning saying, your mother fell, and my daughter was, 3 months old, maybe, and I'd say, Dad, there's not a lot I can do here. So probably the most humbling thing I ever did in my life was, as I knew things were getting bad, and my concern was that she was incontinent at night, and my father was getting up and changing the bed, something he probably never did in his lifetime. But also her skin was breaking down, and that's what I was most concerned about. So one day, after leaving Clinton Hospital, I drove to Leominster, where my mother lived. I said, come on, Mom, we're jumping in the tub. So dressed like this, I took my shoes and socks off, rolled up my pants, we went in the bathtub. Because I wanted to see what her skin looked like. And it was breaking down. So the risk of sepsis and various other illnesses were there. So, and that wound up happening. So we had to make the decision. Did I like it or not? And I had to make the decision with my father, who was crying, saying, I really wanted to give you this, or I really wanted your sister to have that. And I said, Dad, you never did anything for us? Really? So we figured that whole piece out, but then we got to the point of she needs to be placed. And I said to my father, and I said to my sister, who lives in Virginia, who was on top of things, but she's in Virginia. Go away. I will tell her. And the reason I did that is because I was the baby, and I was her son, and I knew she would be mad at me for about 15 minutes. And she was. And she wound up going to a facility. She wound up going to River Terrace. And she wasn't happy. But the next day, another lady moved in there who was just like her. I mean, really just like her. And the two of them used to sit on the couch at the front entrance of River Terrace conspiring how they were going to leave. So what I had then created was a structured activity.
I didn't hear.
It was I created a structured activity for them. Every day they were trying to figure out how they were going to get out of the building. They never left, but they were always trying. They were always thinking about it. So think about that, though. Was that cruel? Or did she have a focus? Did she have a purpose?
And
This was and a friend.
Yeah.
Exactly. And that's my point of this, is, you know, did I want to see my mother in a nursing home? No. Did I ever think my mother would be in a nursing home? No. Do I want anybody to have to do that? No. But you got to think about what it does to you. Could I have taken care of my 3-month-old daughter, spent time with my wife, tried to do the things I was trying to do, tried to take care of my father who was older than her,
And work for a living.
and work for a living? Exactly. So I don't want to see any of you ever have to do this, but there is a point where you have to look at it that way. Because can you really deal with all this stuff? Can you really deal with, we're going to talk about the biggie next. I'm going to talk about agitation. Go ahead, I'm sorry.
You were just talking about building a structure for them.
Yep.
Okay. What would you do in a case where an individual is always asking for more money because they're afraid they may have to leave there? They're in there already.
They're in the nursing home already?
They're in the nursing
Okay.
home already. And then they may have to leave there.
Mm-hmm.
So they want to have enough money in case they get thrown out because
Mhm.
they're not behaving.
Mm-hmm.
I mean, would you continue to give this person money so they can stash it?
Well, my suggestion to that would be, yeah, you can give them money, just try to figure out where they're stashing it, and if they lock it up somewhere, make sure you have the other key. I'm going to tell you a story about a man I had when I worked at Worcester State Hospital,
Okay.
who was a junk dealer. Now, he was a junk dealer. He nowadays they call it hoarding. But, and he was, that's what he did. He collected junk, he sold junk, he did that. So, he was unfortunately on an adult unit at the state hospital, meaning that he was mixed with people from the age of 16 or 18 to 90, okay? And he was a pretty frail old guy, but he was feisty enough, and honest to God, he'd go to UMass across the street for a medical appointment, and he'd come back and he'd have a blood pressure cuff in his pocket, he'd have all kinds of things he'd bring back as gifts. But he used to walk around the unit, and again, 18-year-old kids are on this unit, and he'd just take things. And then the young kids would hit him, because they didn't know any better, okay? So one of the aides was clever enough to get him a locker. So he would go and he'd take his stuff and he'd put it in the locker and whatever else he had. But the aide had the other key. So at the end of the day, the aide would go to the locker, take the stuff out of the locker, and then again, structured activity. It was a very clever thing to do. I don't know the circumstance with giving the money, and do you know where the money's going after you give it to them?
We know it's being stashed.
Okay.
We have been instructed not to give her more than,
Well, see, they don't want to give her something where she could call the cab or get an Uber or whatever it is she's going to do, or him. But I might say that you could always, say, hey, look, I got a place where you can lock that money up, and give her a lock. But just make sure you got the other key, because then you can always get rid of the money.
that's a good idea.
Yes.
What do you think, Joe? Good idea.
It's
Do you all work together?
just,
We have a relative.
Sister-in-law.
yeah, but I'm not saying it will work, but it's certainly worth a try sometime, because you're controlling it in a sense. I mean, you really don't want them to have a lot of money, because, and again, you know, people who have dementia, it doesn't mean they don't have moments of clarity.
Exactly. Does it
Right,
mean
Joe?
what?
They have moments of clarity,
Okay.
where all of a sudden, hey, I know what's going on. Or they say something to you and you go, what? Who are you? You know, you couldn't remember your name 10 minutes ago, but now you're telling me something that was right on target. See, that's the other thing that gets everybody. You know, we can talk all we want about these behaviors, but it's not always the behaviors, it's those moments where you're going, how did you remember that?
Yeah, the real you comes through.
Really? You know, and that's where some of the other stuff that we're talking about gets, you know, there was a lady, I'll always remember her, because I knew her husband from a nursing home that I did a little work with, who wound up coming to the hospital. She was an old nurse, sweet lady, wonderful lady, caring lady. And every once in a while, her husband would know her, comment about something, and each time that happened, she'd say, see, he's getting better. So we could never get her to the point of saying, this isn't good. You know, he's getting up and leaving, he's doing this or he's doing that. So you couldn't really talk about, maybe it would be better if they were in assisted living, or maybe they would be better if they were in a nursing facility. It was hard for us to get there, because every once in a while he'd know who she was. And that's what happens to a lot of people who take care of people who have these kinds of illnesses. It's not that they can't do it, but it's that moment where, because you always have that hope. You know, maybe they'll get a little better. Maybe this will go away. Maybe they won't do that anymore. And they do something and you go, what? But it's a moment in time.
I think in my own case, I've misinterpreted that moment of awareness as this person really does know what's going on.
Yeah.
And I said, they're trying to fool me.
Yep. And that happens to lots of people. That happens to lots of people. Especially early on. And then, but as they start to move into these phases where you start to see the restlessness, the agitation, the wandering, they're starting to move into a phase that they're much less able to do things. And even at the beginning, you know, as we all age, and I can speak, you know, you don't remember everything. I'm sorry, you just don't. But some of that, see, the difference between that, what one would call, and I don't know how to, there's no such thing to me as normal aging, if you will. I mean, we age, but that's what they call it, normal aging. Well, it's not really normal, but there are things that do happen to us. We don't remember quite as well anymore. We're not as nimble as we used to be. We can't do certain things that we used to do. What's difficult with dementia is you have to be able to know that, but separate that when you start to see that it's just not normal. Like, they used to drive to the store every single day at 10 o'clock in the morning, and now when they're driving the store, they're winding up in Boylston, or they're in Worcester, or they don't know where they are. That's when you start to say, that's not quite right. It's those aberrations that begin to occur. It's where they're a little more at risk, they're a little less safe. Their judgment isn't as sound as it was. They do have a moment of clarity, but then, where are they now? I like to call it dementia charades, because that's kind of what it is. It's sort of like taking a stab at where they are. You know, it's no different than when I lived in Worcester for a period of time. I lived right in the middle of a Hasidic Jewish neighborhood. And on Friday night, I might get a knock at the door. Actually, they couldn't really knock, so they'd come to the door and I'd look at them and they'd say, uh-oh, something's gone wrong, right? They couldn't tell you what they needed because that was against their Hasidic faith. So I used to call it Jewish charades. And they used to smile and laugh at me, but it was the truth. I'd have to say, okay, what happened? All right. So I'd say, you need something at your house, right? And so I'd follow them over, and somebody had turned on a light they weren't supposed to turn on or do something, so I would do that. It's a little bit the same thing with this, and I'm not being crass about this. It's like, one of the reasons why people do fairly well at Clinton Hospital sometime isn't just because of the medicine and the real good care that they get, it's also because there's a routine to that hospital. There was a routine to our unit, the way it worked, the way things happened, when the meds were given, when the meals occurred, when the groups occurred, what was going on. And part of that was done as a way to try to make it a little bit easier. We were trying to anticipate the questions they were going to ask or what their needs were before they happened so that they wouldn't get mad. They wouldn't get agitated. You know, because some of agitation is about they can't tell you what it is they need. So what do they say about agitation? You know, one of the things you always check with agitation is pain. Are they in pain? Can they tell you they're in pain? There was a nurse at Blair House of Worcester that I worked with who we had a patient who was just getting agitated all the time. One day she gave her 2 Tylenol and the agitation went away. She had a headache, but she couldn't tell you she had a headache. It was learning to look at the cues of what they do to anticipate what it is they need. And trying to help figure that out. And then you may not make all the agitation go away, but if you can lessen the anxiety that's behind the agitation, the what they can't tell you, you can help. And sometimes you don't have to medicate them. Sometimes you do, because there's no way you're going to reason with them. They're sort of beyond that point of it. But these are the kinds of things that start to occur. And you know, that moment of clarity that you might misinterpret, that's not that uncommon. It's truly not. Because really in your heart, you don't want this to be happening. So you see a glimmer of hope, you're going to jump on that glimmer of hope. It's not unreasonable. And it's not unusual to me. The thing is to try to put it in perspective, which isn't always that easy to do.
It's like when I walk down cellar to do something or look for something, I get down there and I can't remember what the hell I was doing down there.
Oh yeah, and we all do that. You know, we all do that. That's right, and I do that too. So my father gave me a trick. He said, you know, when you're going one way, if you got more than one thing to do, just do it while you're there. So it's like you can always find something to do when you're down in the cellar. So you might not remember what it was, and then when you get back upstairs, you say, "Oh shit, I know it was this I wanted to do." Exactly. So I mean, that's very true. That's very true. It's when you go down the cellar and you can't find your way back up that you start to worry. And that's the different point. You know, you can go down the cellar and say, I don't remember what I was here for, but I'll do this, and then you can find your way back upstairs, and then you remember again. But when it gets risky is when you don't know how to get back out of the cellar. That's when you know something ain't right here. But you're not going to know that, but somebody else might see that. You're going to think, it's all right, it's not a problem. You know? The 2 ladies who were driving, 290 has been very, very helpful to Clinton Hospital in terms of admissions to the 3rd floor. I had 2 ladies who just kept going up 290 and went actually into the bridge. That's the way the car was going till the police came. They weren't hurting themselves, but they were hurting the car. But it's you never know what you're going to see. Now let me spend a couple more minutes talking about, besides these behaviors, I want to talk to you just about a couple other things about dementia in general. I'm talking a lot about Alzheimer's disease, but Alzheimer's disease is not the only game in town when it comes to dementia. Vascular dementia. What is vascular dementia? Vascular dementia is related to your ability of your blood to circulate in your body. If you have heart disease, you can be at risk for vascular dementia. I mean, just because, the heart's not ticking the way it used to because maybe it's a little more clogged or there's something going on. Well, if it's going on down there, it's probably going on up here. And you got to think about that. Seriously, you got to think about that because that is a risk. What do they say about dementia in general now and what you do to be better and what you do to try to avoid it if you can? And I'm going to talk about something at the end about a very recent study that was done and how important that is. But exercise, walk, do things for yourself because all of those things actually do help in trying to prevent from getting dementia. I'm going to talk about hereditary in a minute and that. And that's why I'm going to say this to you. But people get vascular dementia. People have things, their brain is, their brain's not working anymore because they're not getting the same blood flow. They might have had a stroke. When people have a stroke, that could be a cause and effect of somebody getting more cognitively impaired. There's also something called vascular depression. People who have strokes often get depressed. And it's treatable. You can treat them with an antidepressant. You may not treat them forever, but you treat them. So just taking care of yourself, taking care of your diet, getting some exercise, trying to sleep, all of those things that they tell you to take care of your heart actually takes care of your head too. It really does. It's really very important for you. If you don't move, you will lose it. Way too many people I see who get sedentary, and I get worried when you get sedentary because that's sometimes not a good thing either. And we all get sedentary, we all get older. I have diabetes, and there are days when, even though I'm doing everything I know how to do, I just don't want to move. But you really got to move. You got to keep moving because the more you move, the better it is for you. Let's go to that hereditary thing for a minute. One of the biggest questions I always hear, well, my mother had it, does that mean I'm going to get it? We read a study that talks about there's really two kinds of genes that we have that talk about hereditary. We have what they call risk genes. Risk genes are, there's an increased likelihood of getting a disease, but there's no guarantee it will happen. Okay, so my father had cardiac illness, it's a pretty good risk I'm going to get cardiac illness. But it doesn't mean I'm going to get it. There's also something called deterministic genes. Deterministic genes are genes that we have are directly related to a particular disease you have, and that whoever has them is going to develop this disorder. The best one I can give you for that is Huntington's disease. Huntington's disease is a neurological disease. It can cause dementia with people. There is actually a test that they can give you that will tell you whether you're going to have it or not. And I know people who had siblings and parents and whomever and didn't want to get it. There's others who want to know. When it comes to dementia, the only gene that can do it is this deterministic gene. And the likelihood of you getting dementia because of this deterministic disease or gene is less than 1%. Less than 1%. There are some people who will get it. I think the majority of the people I've seen, and probably you too, Mary, is people who get it young. People who start to develop a dementia that is happening in their 50s. The youngest I've seen is in the 30s. I'm not kidding. We've seen some nasty things through time, and you do this long enough, you see things you don't necessarily want to see, but it's good you see them because you understand they can happen. But you get these people who sometimes have some crazy variant that's happened to a gene. We recently, in the last few years, had a young lady who was on our unit who was pretty impaired and pretty nasty and violent. Well, her mother, her aunt, a cousin, they were following all of them. So that's more that deterministic. They have a gene that's clearly going to cause it, and it's probably going to cause it. But generally speaking, it's not a cause and effect. Just because mom had it or just because dad had it, you know, you're more likely if dad had a heart disease or mom had heart disease, that might be more the risk factor than anything else. So you take care of yourself and you try to do something about it. Now I'm going to talk about one other thing, and then we can talk about whatever you want. There's a study I just read about the other day, and I don't often read a lot of this stuff because by the time I get home and I sit down and read, I fall asleep. So I'm being very true and honest about that. But I want to talk a little bit about Alzheimer's disease and something I just recently read. When you get Alzheimer's disease, the hallmark of Alzheimer's disease is beta amyloid and this tau protein. And what that does, and what those two things do, is create what they call plaques and tangles. Okay, a lot of people have heard about Alzheimer's disease and the plaques and tangles. And the theory was that we've got to figure out some way to get rid of the plaques and the tangles. Well, the latest thing that's come out from a couple of neuroscientists who are in the Boston area is that they figured out that the plaques and tangles are actually a fairly normal protective factor of the brain that attacks bacteria, fungus, yeast, viruses that cross the blood-brain barrier. Okay, so what this has led to is a lot of research about how do we try to prevent these viruses from crossing that barrier. Because what happens when they cross the barrier is the plaques and the tangles are formed to surround the virus. The problem is that once it starts, those they can't quite stop those plaques and tangles from keep going because the virus is still there. So what they're talking about is trying to figure out how that occurs before these plaques and tangles start, which will in effect lessen the risk of this occurring. And what some of the things they talk about is diet, exercise, keeping active, keeping busy, and trying to do that so that these things don't start to happen. But that's a much different way of looking at this illness than has been looked at this illness. And they actually, I don't know how they did it, but they did create in a little petri dish, you know what they do that, and what we all learned when we were in biology in high school. They actually did that with a cell, where they introduced a virus, and the plaques and tangles started to form around the virus. So there's something to be said about this, and I'm bringing this up because I'm not going to see it in my lifetime, but there is hope. There is hope. They've done a smell test where that sort of people they think might work. There's a number of different things that are happening. But this was intriguing to me because this was a much different way to look at that and what's happening with it. Illness as well. People who have mental illness, it works in a neurotransmitter called dopamine. One of the things that happens is they have hallucinations. Well, one of the things is because they probably have too much dopamine. When you get Parkinson's, you have too little dopamine. So they give you drugs that increase your dopamine.
Right.
Guess what? You hallucinate. So it's this constant balance of trying to figure out how to make that work. Most of the drugs that you treat agitation and behaviors with right now are antipsychotic drugs. Drugs that are really not made for dementias, but they are made to work on the behavior that occurs as a result of the dementia. Parkinson's being one. It's pretty clear that if you get Parkinson's disease, eventually you'll get a dementia. If you live long enough, many, many, many people wind up with some level of dementia. And there's another type of dementia called Lewy body dementia, which is very similar to Parkinson's, and they mimic each other a little bit. But again, the part of what you're talking about is this whole little neurotransmitter called dopamine. And when you're mentally ill, you're trying to lessen one. When you've got Parkinson's, you're trying to increase one. So when you give them the antipsychotics that they'll do, they sort of fight each other. There's one that doesn't, and I've seen that one work. But that's part of the Parkinson's puzzle. Now they're actually finding ways to treat Parkinson's where they actually put some sort of electronic or electric probe in the brain that helps to change the signals, and they're getting pretty good with this one. But inevitably, if you get Parkinson's disease, you're probably going to get some cognitive impairment of some sort.
And what was really strange is my father lived longer than any other male in his family line.
Mm-hmm.
He was about 85, I think.
Mm-hmm. And like I said, 85 is that magic number.
Yeah.
It becomes a 50-50 proposition about dementia at that point. And just goes up with each passing year. And they say, you know, from 65 on, every 5 years it jumps. That the risk becomes greater.
Going back to the symptoms of Alzheimer's in general, is there any particular place with the symptoms where you would say, now's a good time to start thinking about extra care, like nursing home care versus assisted living?
Good question. Good question, because some assisted livings now, you know, have dementia units or dementia care areas. I think those are good, but if the patient starts to be wanting to leave a little bit more, not sleeping a lot at night, the things I'm talking about,
Okay.
that's when you start to think about it. Things like hallucinations, hallucinations, Parkinson's, clearly it's very much a hallmark of that. Lewy body, it's another one. They have one of the theories is that they have vivid nightmares, and those nightmares become reality to them, and they try to live them through the day. There's no great cure for that. There's no one medicine that seems to work for that particular illness, because the hallmarks are that they have trouble walking, and most of the medicine doesn't work, no matter what it is. Doesn't seem to work. As they get more impaired, that's when you have to start thinking about it. They even talk in here and things I've read and things I've watched about one of the reasons why hallucinations stop after a while. It's not just the drugs; it's that the people are getting more impaired, so they really can't describe them. So that's part of the reason they go away, because they can't really tell you that they're having them anymore.
Much like the pain, they can't describe it.
Right. It's very similar to that.
Yeah.
So as you're moving into the later stage of a dementia, the sort of end stage of it, it doesn't mean that some of this stuff goes away, but as you get more impaired, you're less able to verbalize it and figure out what's going on.
Right.
Good. And the hallmark of Alzheimer's disease is there's a lot of language issues. I can talk about different things I see. Alzheimer's disease is a lot about language. They can't say things. They have trouble with words. And it gets worse and worse and worse. People who get vascular dementia, to me, sometimes they're right on the button, but other times, oh my God, they're in Cleveland. They're not even close. But what I see with that is I'll ask a family a lot of times, what were they like? What was their personality? They'll say, well, they were energetic, they were vibrant, they were doing this, and all of us, and I'll say to them, so what do you think? Has that gotten bigger? I'm like, oh yeah. That's what I see. That personality, that piece seems to grow. People who have a particular kind of dementia called frontal temporal, which used to be called Pick's disease, and I still have a vision of a person on my unit who had Pick's disease at the age of 50, who was a physician, who was an AIDS researcher, was a brilliant man, and my picture is him sitting in front of the nurse's station with a brief on, in a jerry chair. And I'm thinking about, look at who this man was. He was a medical doctor. He was a brilliant man. And now he's sitting over there. I mean, it's awful. It's awful. But those kinds of people have dementias that affect their mood and their behavior in a different way. They get very disinhibited. That's the nun story. That's true disinhibition, you know? Or the person who, you know, is driving in a car and, you know, somebody cuts them off and they want to say whatever they want to say and they don't say it, they can inhibit it. You get dementia, that's gone. There's no brakes left. It's gone. It's gone. I walked in the unit one day, a female patient looked at me and said, "You're old, you're fat, and you're ugly." I said, "Really? You didn't miss anything, did you?" What are you going to say? What are you going to say? It's the nature of what's going on with them. And that's what's so troubling for people. You know, oh my, they never did that. They never said that. They never did that. And, you know, sometimes I have to quietly say, but they never had this illness. It's not them. It's what the illness is doing to them. It's what it's robbing them of. Who they really were, what their personality was, you know. My father-in-law, you know, he's a dear, dear man, you know. The one thing I could get him to do with hermits and a glass of ginger ale, he was good to go with a hermit and a glass of ginger ale, the old sweet he was. You know, but now he's had moments where he swatted somebody, you know, and because of what I do, you know, the clinician will call me up going, "Your father-in-law's doing this." I said, "Well, you know, it's like, do what you got to do." I mean, you know, I just know it. I just know it. But underneath all of them, even though all this bad stuff goes on, usually we see some glimmer of who that person was.
Does dementia ever get misdiagnosed?
Yep.
I mean, if an individual can live their life being mean, being agitated,
Oh, yeah.
being selfish,
Oh, yeah.
being demanding,
Yep.
is there a difference between these two?
Well, I think the difference is when that mean and nasty stuff starts to jeopardize not only him but everybody else around him, and he's more at risk. I mean, yeah, people can be misdiagnosed. That's part of the reason why I said everybody's checked medically before they're coming onto a unit, because there are things that occur.
How many have we had that come in and the family thinks the patient has dementia and they have a urinary tract infection,
Right.
which causes confusion in the elderly?
Right.
Many, I mean, we've seen many up there
Yes.
that come in and they get on meds
Yep.
for UTI and they're like, fine.
Yeah,
Right.
things are much better. Or depression. Or depression. Depression, you know, the question about depression and dementia mimic each other. The way I'll tell you to think about those two things. People who are depressed are generally worse in the morning and better as the day goes on. People who are impaired cognitively are usually better in the morning and then worse as the day goes on, the infamous sundowning that you hear about. I mean, it's not as cause and effect at that, but it truly is what you see. I mean, you talk to a depressed person in the morning and it's gloom and doom. But later on in the day, maybe they're up, maybe they're moving, maybe they're feeling a little better. You know, it's not quite as bad. Walk on the third floor of Clinton Hospital at 5 o'clock. It's not a pretty thing sometimes. It's just not.
God bless those nurses.
Yeah, exactly. I mean, it's very challenging. People are moving. It's time to leave. Time to go home. I'm ready. Where's the bus?
The nurses, oh.
Yeah, I mean, it's you know, it's
home now.
exactly.
One more point, if an individual has been diagnosed with having the mentality of a 10-year-old,
Yep.
how does that compare to a person that has dementia? Because it seems like the 10-year-old is a brat.
Well, not necessarily, but if people who, I mean, how would I differentiate that? People who might have a developmental disability might not have the social skills and the wherewithal to be able to do some of the clever things a person with dementia might be able to do.
Exactly.
I mean, that's a tough one. Now, mind you, people who have Down syndrome, it's almost 100% that if they live long enough, they'll get Alzheimer's disease. I can't tell you why, but that's true. Yeah, well, think about it. How many Down syndrome people do you see living into their 60s and later life? You don't. You don't really see that. Now, I'm guessing as time goes on, that will improve, that people will, but it's not, you see it.
Right.
You see it. There's nothing nice I'm going to say about dementia. It's not a pretty illness. It's not a nice thing. It's a terrible thing. I feel for every family I see and every person who gets it. You know, I have to, in what I do on a day-to-day basis, I mean, if I took all of this stuff to heart, I might as well just stay home and stay in bed, because I'd be a blithering idiot. But you gotta be there to support. You gotta be there to offer and do what you gotta do. But it's an awful illness. It's awful. There's nothing, you know, it's terrible. It's not the person you knew, and that's the thing that struggles with everybody. It's a living death. You know, but we need to do a better job of dealing with it. We need to do a better job of trying to figure out why it happens. We need to do a better job at supporting the people who have to deal with it on a day-to-day basis.
Yeah, support is missing.
Support it, and you got to get out. You gotta, and again, if you can, you know, if you're able, you got to get out. But you also got to take care of you. You have to take care of you, because inevitably it will take you down. It will do it, without a doubt. I've seen it way too many times.
How many times have we seen the caretaker go before the patient?
Exactly.
Yeah.
Absolutely. Mary's right on the button with that. Absolutely. You know.
It's so demanding.
You know, the other side of that is, how many patients have we seen that come in wild and agitated, and 3 months later I'm reading their name in the obituary?
They're what?
I'm reading their name in the obituary. You know, they talk about the calm before the storm. I talk about the storm before the calm. You know, it's that last hurrah almost, you know, let it rip. And then it's gone.
They do.
Yeah, and they do. Believe me, they do. Yes, they do. Yes, they do.
Another thing is, people always try to reorient and bring them, you know that's not happening, and it only makes it worse. You know, if you're better off to kind of like,
Go along.
yes,
Play their game.
yes.
Go along with it,
Change
yes.
the subject, or, you know.
And that's more what it is, right.
Where's my mother? Where's my mother? Well, you don't want to say, well, your mother's dead, you're 92 years old, you know. You can't explain to her the truth, you know, so we would say to her, well, what was your mother's name now? Let me think, you know, when we talk about her mother, then she forgets she was looking for the mother.
Exactly.
And it takes the agitation away, it takes all that others away. You know?
Perfect example, because that's so true. You don't want to argue with them, because what are you arguing?
You have young aides, like, they don't understand that this patient has dementia. No matter how many times you work with them and say, you know, he's not doing that on purpose. They're not doing that to get back at you, because that's how sometimes they feel, these aides, you know. And so you have to keep telling them that that's not them that you're seeing there. That person has a disease. You're treating their disease, but there's still a person there.
Right.
So it makes it hard, you know, like when you're the nurse and you gotta say to the aide, don't agitate him like that. you
Don't
know.
react.
Yeah,
Right.
let me take him and see,
Right.
because they don't understand either. They think that the person's hitting them because he feels like hitting you. He's not hitting you for that reason, you know,
Right.
but it's very frustrating. I know, as a worker, as an employee, I did it 26 years,
Yep.
so it gets to you after a while.
Yeah. I used to
And your
apologize.
disinhibition, you know, they call you
Yes.
your name in the book.
Oh yeah, it takes tough skin to sort of deal with that. And as Mary's saying, they can't explain to you what it is that's going on.
Right.
So if you're going to argue or try to reason with them, You don't know where they are. I mean, I kid with this, but, sometimes they're in Baltimore. I don't know where they are. It's this whole, what I just said about dementia charades. I mean, that's kind of what it is. It's you don't react to what they're saying, you react to the mood you see.
I guess I'm kind of like in a place where I grew up with this individual.
Yeah.
She was nasty.
Yeah.
So I don't see any difference in her, even at this age.
Yeah.
And that's what I'm struggling with.
Right.
You're wondering if she's had dementia all of these years.
Yeah.
She's not demented.
Right,
Having an
right.
issue.
Well, and I can't answer that really well because I don't know, but you're right.
I don't see any difference from when we were children, youngsters, and her now.
Do you find her more confused?
Pardon me?
Do you
Well,
find-
She's been confused all her life.
Okay, then maybe it is just part and parcel of who she is. It could be.
Like a mental disorder, right?
Could
But
be.
she is developing other symptoms, like the incontinence, like not sleeping well at night. That type of, hallucinations.
Yeah, the hallucinations.
Those
yeah.
kind of things are starting to.
So more than likely, she's getting something in addition to what she was before.
Okay, all right, because that's kind of where I'm at. with
Yeah,
it.
and I mean,
Nice to her,
if-
I want to be kind to her.
well,
It's really
and you-
difficult. I
and-
think she's faking it.
Yeah.
Which is what you were saying.
And I'm not alone here.
Yeah. No. Sometimes it's hard to figure that out or tease that out. Absolutely.
So you feel like you're being played by your...
Yeah.
You do, absolutely, yeah. She always talks about her money. Money's
Money's a big thing with these.
Oh yeah, money's really
Oh,
big.
my God. We use
Well-
Monopoly money once in a while.
Yeah, money is a big thing. Money is a big
Yesterday,
thing.
I keep giving them a step, just make copies of money on a copier.
Yeah.
Right.
Give her the paper
Ooh,
copy.
Well, it also.
Good idea,
Great
thank you.
idea.
There we go.
See, and that speaks to what I was talking about, the boomers. I'm a boomer, and so boomers had their way. So I'm saying, okay, forget the millennials. You're going to tell me I can't have this? Right? All right, so think about that. But also think about what you're talking about. People grew up in the Depression.
Right.
What do they want?
Yeah.
Money.
Money, yeah.
Money.
Exactly. Yeah.
Money.
It's all about money with her.
And it's because I don't want to be without.
Exactly.
I don't want to be without. So it's not the money, it's the context of where they are with it and what's going on with
The
it.
security of it all.
The security of it all, exactly. I mean, the patients we have who you talk to their family, they said they got rubber bands. I got a ball, it's this big, it's all rubber bands. Is it hoarding or is it that they grew up in the Depression?
Wow.
I always used to kid my father. My father grew up in Canada, and he came to the United States in 1929. I said, "Not a good year, Dad. Wasn't a good plan." And he chuckled. But I mean, it was the reality of it. But honestly, I mean, for a long time, I mean, we're sort of moving out of that age a little bit because people are getting older and beyond that. But my God, it was like, where's my money? Where's this? It's the need to have that security of the time.
I was just thinking, you can buy fake money that looks very much like real money.
Yeah, you
But
can.
I'd be afraid that she'd try to spend it and get arrested.
You're right. You never know. You never know.
The good thing there is she's paranoid about leaving the place. So she won't even go to the bank and set up this little account.
Well, maybe you can start using that fake money then.
Take money.
Yeah, she's afraid of getting lost now. That's
Yeah,
another
that's
Another one,
symptom.
paranoia.
Yeah, exactly.
It is another symptom, and that's a big symptom because it's not so much that they get confused and whatnot, but it's when they start getting lost and when they can't reason their way through something that they used to be able to reason their way through.
And that's what she's...
That's where you start to think about, ooh, something's not quite right here.
Yeah.
Think about it, she doesn't want to leave that place.
Yeah.
She doesn't want to go walking.
She does not. No.
Yeah.
Because she's got a sense of security in that building. She knows where she is.
Yeah.
But yet she's still saving her money in case she has
Right,
to throw her
right.
out.
And that's her personality. That's her personality.
Yeah.
That would be her personality to me, but the rest of it is what's starting to occur.
Okay, yeah, no, you're right. Yeah, the personality is.
Because it's personality changes. I mean, that's a biggie. That happens in all of these. Like I say, vascular people, I just see, I look at them and go, ooh. And then you ask the family, yeah, they were this or that, but now it's like this big. So you know something's amiss here. You know something's not quite right. But all the stuff you're talking about is all the real deal.
I have a friend told me a story when she was in first grade. They were going to keep her back, and they didn't know whether or not it was because she was stupid or retarded. And so the teacher decided, well, she would go to the house and speak with her mother and see what her mother thought about keeping her back. And she got to the house and found out nobody spoke English. So my friend had sat there all through first grade without a clue what was being said.
Wow.
See, that.
That's a biggie.
Yeah, but see, that's sometimes when you do a little digging,
Yeah.
that's what you see. So you realize that, oh, this is a little bit different than I thought it was going to be.
Yeah.
So
Yeah.
And today she doesn't even have an accent.
She did good.
So to the point of being played, are people able to, you know, if they try really hard, perform when there's other people around, or when they're at the doctor's or whatever, and everybody says,
That's the great-
"He's doing so great."
That's the great story. Oh yeah. Oh yeah.
Hello.
Oh yeah. Oh yeah.
See the real.
You
Yeah.
didn't see last night.
So here's what you do. I'm sitting in the neurologist's office with my mother, and he's examining her. And he's asked her a question, and she looked at me. He asked her a question, she looked at me. By the third question, I said, "Hey, Mom, I got to go get this phone call." Because then he was one-on-one with her. Because he was examining me, and I didn't want him to find out what was going on with me. But seriously, and I know what you're saying. They can do it really well, and you got to look back. You got to look when that's not happening, and kind of watch what's going on.
Except for I'm the only one that sees it,
Oh,
you know?
It's you.
So it's you, yeah.
And, right, and, you know, I mean, even if my husband just steps into the house, she's like, "Oh, hi," and suddenly her back doesn't hurt anymore that we were just at the doctor's for an hour ago, and she was moaning and her, "Hi," and she's twisting around, and it's like, huh? Like, what? And my husband says, "She's playing you." I'm like,
and he might be right.
I don't think so.
It's like we go to visit my sister. "Hi, honey, how you doing today?" That's me. "I'm all right." And then my brother comes behind me. "Oh, hi, Joe."
Yeah. Oh yeah.
Right?
Yeah.
There's nothing wrong with her.
That's what goes on.
Oh, I'm telling you.
The other thing you were talking about, the sleep being off.
Yep.
I was in rehab after my surgery, and you know the lights go out at 8 o'clock,
Oh yeah.
and that's not the way we live today. At least today, now everybody's got a TV in their room, so you can sit up and watch.
You're right though, but that becomes very dysregulating.
Yeah.
It becomes.
In the rehab, the lights may go off at 8 o'clock, but they also come back on at 9, 10, 11.
Or, yeah. And the doctor only comes in at 6 a.m.
Well, we had one who came in at 5 a.m. They were fine.
Yeah.
They wouldn't not a peep out of them. Yeah, right.
Yeah, it's a tough one. It's a tough one.
Oh, it's all of this
Yeah,
is
it's a lot
all of
work.
this.
It's a lot of work.
Anybody.
There's not a lot to stimulate you, stimulate your mind.
And that's also, as talking about some of the stuff that they're talking about, is that's one thing they will say. You got to keep yourself mentally and physically active on some level. It doesn't mean you have to run down the street or jog at 12 miles or read 12 books or whatever. Just keep yourself stimulated a little bit. Take a walk around the block. Walk to the store instead of driving to the store if you can. Do crossword puzzles, do word searches, do something that's going to make you think outside of yourself and use your brain a little bit. And again, it doesn't have to be, I'm doing the theory of whatever. It's just keeping yourself a little mentally active and try to keep yourself a little more mentally sharp. And if you're noticing things or things aren't going well, that's when you may worry a little bit. But it's not a cause and effect all the time. You know, it's just not.
How do you know when the person is safe to be alone? That's my other big issue. My mother has her own house. She lives alone. She's 91. And I had to put a doorknob on the door to the basement with a lock on it because she's a fall risk. And she thought that she had to go down and do a little vacuuming down there, and so she unplugged the cable box, and then she called on her cell phone at 11:30 and said, at night, my phone doesn't work, I don't know what's wrong. So my husband went over and he said to me, did you run the vacuum downstairs? And I'm like, no. And he said, well, the cord, the cable box got unplugged and the vacuum's plugged in. I left her house at 10:30 at night. So sometime between 10:30 and 11:30, she went down in the basement to vacuum.
Oh my gosh.
Just a little bit in front of the washer and dryer. That's all. And she hasn't been supposed to go on the stairs unless someone's there for like a year and a half. So now the cellar door's locked, but she still has the second floor, which is open. There's no way to close it. There's no door on the stairway. And I mean, I keep saying, I don't know, I think I need to move over here because you're doing a lot of things that you're not.
But if you say that to her,
And
she's
she
not going to
says,
tell you.
I'll let you know when that.
Right, yeah. I've heard that one before. Yes, I've heard that a few times. I've heard that a few times.
I'll be waiting for that call.
Yep. It'll be a long distance one, too.
She's at the bottom of the stairs.
Yes. You know, that's a hard one, and that's hard. But it sure sounds like things are starting to not be as good as they were.
Yeah,
And I think you have to start planning for what you're not going to want to do.
yeah,
And she's not going to want to do it. She's never going to tell you that anything's wrong.
right.
So
But-
how do you get them there?
How do you get them there? Well, sometimes you have to maybe force the issue a little bit.
Tough love.
Yeah.
Blame the doctor.
Yeah.
Blame the doctor. The doctor said.
Yeah. Yeah, sometimes you can do that. I've used the doctor said before, because this is still an error of the doctor said.
Yeah.
If it's getting to a point where you think they're genuinely in danger, or endangering themselves, you have to do something. Or you should do something. Let me put it that way. I can't say you have to. You should. Because the next call is going to be, they've been hit by a car, or whatever it is,
Well, that's the call that I'm waiting for.
Yeah.
Because she lives in Florida, and she lives alone, and there's no one down there, there's no
Yeah.
family there.
Yeah.
My brother lives in New Hampshire, I live here.
Yeah.
And she's 94, she still drives on A1A to go to Walmart.
Yeah.
Wow.
Wow, she doesn't get lost in Walmart?
Well,
And the doctor, he had all the nurses in, he had the secretaries in. They couldn't believe I was 94. They just couldn't believe it.
Because she does look really good, and she really does. She looks fabulous. Yeah, she looks like she's in her 70s.
Wow.
it's the butt. It's the butt.
So I've been going down, she's been down there for 30 years, and then they would summer here. And she was just at my house this past summer. And the signs were everywhere. I mean, everywhere. And she couldn't come back here for a winter, because she's been...
She'd been there for so long, yeah.
Cold,
Yeah.
you know. So anyways, my brother is there tonight, and he'll be there tomorrow night. And he's gone down a few times now since the fall, because she had somebody move into the house. Now, she doesn't like company, never mind have somebody move into the house. Okay? So this was a con game of somewhere.
Oh, I was going to say, it sounds like it's not a good thing.
Right,
Yeah.
it wasn't a good
Yeah.
So there was a storm and some rain came in her bedroom and so she told the lady she had to leave. Well, I'm sure after, I don't think she was there 2 weeks, you know, my mother's privacy was invaded or whatever, so she had to ask her to leave. She was from another country and didn't speak English very well. All the signs
That's a little more risky, yeah.
So when this person was going to move in, my mother called me and she said, do you want me to send your clothes to you? Or what would you like me to do with them? Because I kept a closet full of clothes there because I was going back.
Because you would go back and forth, sure.
I was so angry. I said, give them to the church. And she did. She packed them all up. I have nothing there.
Oh my gosh. Yeah.
And my brother, who has called her every day since my father has passed away, I mean, no matter where he is, he calls her every night at 7:30, regardless. She goes, I don't know why he calls me. He just calls to argue with me. I was the one who was there all the time. Everything she owns, I've bought her. And she's from the Depression. She has all the...
She's got it all.
The elastics and everything.
Yep.
Wouldn't spend a dime on herself. I mean, if she wanted an ice cream cone, she'd go without because she had to save it. For what?
Mm-hmm.
And now, I really think somebody's after it.
Mm-hmm.
And it's there to be taken.
Mm-hmm.
Wow. And I'm here, and she doesn't call me.
Have you ever talked to her physician?
Yes. He doesn't like me.
Oh, she told you that.
She told me that. He doesn't like me. So I went to the doctors with her. I mean, you know, every appointment you ever had, I'd be flying back and forth to go with her. And I didn't care for him. And, you know, physicians in Florida aren't quite what I think they are up here.
Mm-hmm.
They're...
One of the things you might want to try, I don't know what they have in Florida in terms of like home care and what one would call protective service. Like in this state, you know, if there's an elder at risk, there's a protective service agency you can call and they'll go out and see what's going on. You might want to call like the Department of Health or Department of, let me see, who could you call down there? A department, maybe a department that works with aging or somebody, and say, do you have like a protective service branch? Do you have an agency that will send somebody out? Yeah, send somebody out and you know, go assess this?
If she ever finds out that I was the one behind that.
Yeah, but she doesn't have to know that. She doesn't have to know. Call the police.
Yeah.
Call the town police and say, hey, look, I'm really concerned about my mother
I want a wellness.
because of this. Do you have an agency that's in town that you could call that, because she's getting swindled.
Wow.
Yeah.
You know, you can do that. You can absolutely do that. I mean, in this state, they have what they call protective services. And I, as a social worker, am obligated, if I think there's a potential for a person being swindled or abused or whatever, I'm obligated to call that agency and say, I think something's going on. I can't prove it necessarily, but it sure smells that way. And this agency is obligated to go and assess this. And I can't imagine that Florida doesn't have that, with the amount of elders that are in that state.
Yeah, yeah.
So, I mean, I know, we gotta go, I know, it's okay.
We can talk afterwards, but he has to stop.
Yeah, you can stop.
Say goodbye.
Yeah, you want to sort of close it out?
I'm done. Thank you.